Everyone, welcome to Surgery Made Simple. I'm Jashan, and in this series, we'll break down high-yield neurosurgical topics for medical students and junior doctors. Today, we are starting with one of the most important emergencies you'll ever encounter: traumatic brain injury. By the end of this video, you should understand what TBI is, how it presents, and how to manage it safely on the ground. Traumatic brain injury refers to any injury of the brain caused by an external force. It's a major global health problem and one of the leading causes of death and disability worldwide. As a junior doctor, you may not be performing neurosurgery, but you'll absolutely be involved in the first assessment, stabilization, and escalation. And those early decisions can change outcomes. So there are many causes of traumatic brain injury. The most common causes includes falls, especially amongst the elderly, motor vehicle accidents, sports injuries, and assaults. The mechanism of injury matters. This is especially so as high energy trauma increases the risk of intracranial bleeding, diffuse axonal injury, and rapid deterioration. Hence, we always ask ourselves, what is the mechanism of injury? So we classify traumatic brain injuries into two important ways. Firstly is the primary versus secondary injury. Primary injury happens at the moment of impact. They include contusions, lacerations, and intracranial hemorrhage. Secondary injuries happen as a consequence from the primary injury itself. It develops over time, and it's a consequence of either swelling, ischemia, or raised intracranial pressure. This is the injury that we can actually influence with good care. We also divide it between focal versus diffuse injury. Focal injuries such as epidural hematoma, subdural hematoma, and intracerebral hematoma. So the top right image shows intracerebral hemorrhage on the left side of the brain. We also have diffuse injuries such as diffuse axonal injuries. Diffuse injury can look mild on CT, but can be clinically severe. The best way to look for it is in the MRI, as shown in the bottom right. So, for clinical presentation of the traumatic brain injury, symptoms can vary widely. Patients can range from headaches, confusion, vomiting, seizures, and reduced consciousness. The most important tool that we use here is the Glasgow Coma Scale, or GCS. The GCS uses a few different types of subcategory: E for eye movements, V for verbal, M for motor response. The lowest GCS would be 3, in which the patient is completely comatose, where the least severe GCS would be that of 15, where the patient is completely awake. Anything less than 8 would determine that the patient has a severe traumatic brain injury, which most likely needs intubation. Other red flags we should look out for are pupillary changes, posturing of the patient, and the deteriorating GCS. Those need to be escalated as soon as possible. First-line imaging for diagnosing TBI would be that of CT brain. It is fast, accessible, and excellent for detecting small bleeds and fractures. MRI is used much later on if we suspect a diffuse axonal injury or subtle structural damages. In severe TBI, you may also see the surgeons use ICP monitoring or EEG if seizures are suspected. Alright, let's just take a look at some of the imaging shown over here. In A, this is the bone face of the CT brain. It's best for looking out for fractures. So you can see there's this fracture in the left parietal area. B, we are looking at a CT brain, and there's this hyperdensity in the left frontal area, which likely shows an intracerebral hemorrhage. Part C shows hyperdensity on the right side of the brain. It's quesenteric, or what we call concave. This points towards a subdural hemorrhage. In addition to that, we can see that for the right side, the ventricles is a lot smaller than that of the left side, which points towards raised ICP. Other features of raised ICP include the effacement of the sulci, loss of gray-right differentiation, or even midline shift. Part D shows a convex or lens-shaped hyperdensity on the patient's left side, which points towards that of epidural hematoma. Part E shows an MRI, which shows diffuse hyperintensity all over the brain, which points towards that of a diffuse axonal injury. Whereas for Part F, looks like an intracranial hypertension. We don't even see the ventricles in this CT brain. Moving to the management principles for traumatic brain injury. Management begins even before neurosurgery is involved. So step 1 will be ABCs, airway, breathing and circulation. So for any patient with a GCS less than 8, as previously said, we might consider intubation in view of airway compromise. Ideally, we want to maintain oxygenation, perfusion and blood pressure to the brain. This is because hypoxia and hypotension both worsens secondary brain injury. Step 2 involves controlling of the intracranial pressure. Basic measures include elevating the head to 30 degrees, ensuring adequate ventilation, and avoiding hypercapnia. Medical therapies such as mannitol and hypertonic saline can also be used. All of these reduce cerebral edema. So step 3 will be that of surgical intervention. When indicated, examples of surgeries that can be done are craniotomies, evacuations of hematoma, and decompressive craniectomies. The decision depends on both the CT finding and the clinical status of the patient. Whereas finally, step 4, rehabilitation. So TBI care doesn't just stop in the ED. Patients often require physiotherapy, speech therapy, and cognitive rehab. So long-term complications of TBI includes post-concussion syndrome, epilepsy, and cognitive defects. Let's look at some landmark studies in TBI management. The CRASH trial in 2004 investigates whether corticosteroids have any impacts on the outcomes of TBI. It shows that corticosteroids do not improve outcomes and may actually increase mortality, hence they are not recommended in traumatic brain injury. The CRASH 3 trial investigates the use of TXA in TBI. It shows that TXA reduces head injury related deaths in mild to moderate TBI when given within 3 hours. The DECRA trial in 2011 found out that early decompressive craniectomy reduces ICP but may worsen outcomes, and hence we might consider using it in severe cases. Whereas the Brain Trauma Foundation guidelines helps us with optimizing the standard of care for traumatic brain injury. So if you could only remember 3 main things about traumatic brain injury, 1 is that TBI is quite a common neurosurgical emergency. 2, early recognition and management are critical, and hence in the event of a deterioration, it's best to escalate as soon as possible. And all surgical trainees play a role in the care of TBI patients, so you don't need to be a surgeon to treat TBI, especially in the early stages. So coming up next, we'll be talking more about epidural hematomas or EDH. Thank you so much.